Hi all, my topic of discussion is diabetes and its complications. So first we will start with the signs and symptoms. So the first sign is glucosuria. Glucosuria, as you all know, it's the presence of glucose in the urine, and as glucose is present in the urine, the more amount of water is also excreted in the urine, which causes polyuria. So polyuria is more amount of water in the urine or more urine excreted, and as more water is excreted, it causes polydipsia and polyphagia. Polydipsia means increased water intake, and polyphagia means increased food intake. Even though food intake is increased due to the defect in the insulin production or in the insulin action, there happens a lot of changes in the body, which increases the protein as well as lipid metabolism or breakdown. So that causes increased weight loss, or weight loss is seen in that individual. And also, as more as glucose is seen in the extracellular fluid in an excess amount, there is an favorable condition for the proliferation of bacteria, and that causes chronic recurrent infections. So the signs are glucosuria, which causes polyuria and which causes polydipsia and polyphagia. And in spite of polyphagia, there occurs weight loss, and also there is chronic recurrent infections. So that's about signs and symptoms. Now coming about complications. There are two main types, that is acute complication and chronic complication. Now acute complication, there are mainly three: diabetic ketoacidosis, hyperosmolar non-ketotic coma, and lactic acidosis. And chronic complications are divided into two: microvascular and macrovascular. So in the acute complications, we will first see the diabetic ketoacidosis. Now it is mainly seen in type 1 diabetes mellitus, that is insulin dependent diabetes mellitus. So insulin production is decreased. So that means glucagon insulin ratio is increased, and that causes lipolysis as well as gluconeogenesis. Lipolysis increases free fatty acids. Gluconeogenesis increases the utilization of oxaloacetic acid. Now free fatty acid is seen more in the body or in the blood, so that causes increased oxidation of fatty acids, and more acetyl CoA is produced. And as the oxaloacetic acid utilization is increased, there is a deficiency of oxaloacetic acid, and so the TCA cycle will be reduced or will be inhibited there. As the acetyl CoA is more in amount but the TCA cycle is inhibited, so this acetyl CoA will go into ketogenesis. As we all know, the acetyl CoA is the initial or the substrate for ketone body synthesis, and so acetyl CoA enters ketogenesis, and it leads to the production, and it manifests as ketosis because of production of excess ketone bodies in the body. So it causes ketonemia, that is the presence of excess ketone bodies in the urine, ketonuria, excretion of ketone bodies in the urine. Or ketonemia means excess ketone bodies present in blood, ketonuria, excretion of ketone bodies in the urine, and smell of acetone in the breath. So these three conditions are known as ketosis. These three conditions collectively are known as ketosis. So once again I'll repeat, the diabetic ketoacidosis, it's seen in type 1 diabetes mellitus, that is in which the insulin production is reduced. So as there is less amount of insulin in the body, the glucagon insulin ratio is increased very much. So this causes lipolysis as well as gluconeogenesis. Lipolysis and gluconeogenesis are increased in our body due to the increase in glucagon and glucagon insulin ratio. So increased lipolysis causes increased free fatty acids in our body, and these free fatty acids are oxidized to acetyl CoA. Now this gluconeogenesis is increased, so it increases the utilization of oxaloacetic acid. As we all know, in the TCA cycle, oxaloacetic acid is an important compound. So due to the increased utilization of oxaloacetic acid, it becomes deficient in our body, and so the TCA cycle is inhibited. As the acetyl CoA is seen more in our body, but it is not participating in TCA cycle because TCA cycle is not occurring. So that acetyl CoA is it enters into ketogenesis and ketone bodies are formed in excess. So it manifests as ketosis and ketonemia, ketonuria, and smell of acetone in the breath is seen. So that's about diabetic ketoacidosis, and the investigations are positive Benedict's test, positive Rothera's test, blood glucose very high, greater than 300 milligram per deciliter, and pH is less than 7.3 because it's acidosis. So pH will be less than 7.3, and bicarbonate concentration will be less than 15 milliequivalents per liter because it's acidosis, and bicarbonate is a basic substance and it's a part of our buffer system. Its concentration decreases, and serum sodium concentration decreases and serum potassium concentration increases. So these are the investigations for diabetic ketoacidosis. Now the consequences for diabetic ketoacidosis are as follows. The consequences are acidosis, it's diabetic ketoacidosis. So acidosis, that is increased anion gap, reduced buffer, Kussmaul's respiration. Kussmaul's respiration is a typical kind of respiration which is done by our body to overact or counteract the acidosis that is occurring in our body. So increased ventilation is seen in Kussmaul's respiration, and increase of potassium concentration in our body. Coma is seen due to the electrolytic as well as dehydration in the cerebral cells, and osmotic diuresis, dehydration, decrease in sodium concentration. So the consequences are acidosis or increase in anion gap, reduced buffer, Kussmaul's respiration, increase in potassium concentration, coma, osmotic diuresis, dehydration, and decreased sodium concentration. So a simple mnemonic for these consequences are ARK PCOD/S. So that is, we all know PCOD disease, PCOD or PCOS. So ARK PCODS. So this is a simple mnemonic for the consequences. Now as we quickly go into the managements of diabetic ketoacidosis, it's insulin IV, that is intravenous injection of insulin or intravenous injection of bicarbonate and or normal saline, and normal saline is for water imbalance correction. So that's the management things for diabetic ketoacidosis: insulin IV, normal saline, and bicarbonate HCO3 minus IV. Now coming into the second acute complication, that is the hyperosmolar non-ketotic coma. And this coma is due to the cerebral cell dehydration, and which is due to the hypertonic extracellular fluid that is seen around the cerebral cells. And this hypertonicity is due to increased glucose level in ECF, which is greater than 900 milligram per deciliter. So here the coma is not due to the ketone bodies accumulation, it's due to the increased hypertonicity in the extracellular fluid, and it is independent of the ketone body production. So glucose level is very high, greater than 900 milligram per deciliter, and that causes hypertonicity around the cerebral cells, and that causes dehydration from the cerebral cell, and it causes coma. So that is the reason for coma in hyperosmolar non-ketotic coma. Now the third acute complication, that is lactic acidosis. So lactic acidosis is rare, and it is seen due to the oral anti-diabetic drugs which are earlier used bigonides. So bigonides are oral anti-diabetic drugs, and its earlier versions caused lactic acidosis. Now newer drugs are used instead of the older one, that is metformin, and modified, and bigonides are modified, so it's a newer version now. So lactic acidosis, it's rare, and it is due to oral anti-diabetic drugs. Now metabolic reason for the lactic acidosis is that the glucagon insulin ratio increases. As we said earlier, the ratio between glucagon and insulin increases, and that causes increased metabolic reactions like lipolysis, gluconeogenesis and all. And many metabolic reactions are increased abnormally. So that causes very high consumption of oxygen. As oxygen is highly consumed, it causes hypoxia, and due to the hypoxia, the cells go into anaerobic respiration, and the product of anaerobic respiration is lactic acid, and lactate is produced in large amounts and it gets accumulated, and that causes lactic acidosis. So once again, the glucagon insulin ratio increases. That causes increase in many metabolic reactions, and it causes increased consumption of oxygen, and it causes hypoxia, which leads to anaerobic respiration. Thus lactate or lactic acid is overproduced and it gets accumulated in our body. And another reason is increased gluconeogenesis, which is also due to increase in glucagon insulin ratio. So gluconeogenesis increases, which causes the depletion of oxaloacetic acid, because oxaloacetic acid is overutilized in the gluconeogenesis, and so the TCA cycle decreases. Because the oxaloacetic acid becomes deficient in our body, TCA cycle also decreases. The TCA cycle is inhibited, or because the substrate for TCA cycle becomes deficient. So the TCA cycle is responsible for the breakdown of lactic acid, not directly but indirectly it is responsible for the breakdown of lactic acid. So as the TCA cycle reduces, the lactic acid will not get utilized and it gets accumulated because of its underutilization. So gluconeogenesis increases, oxaloacetic acid decreases, TCA cycle also decreases, and that causes lactate underutilization and accumulation of lactic acid, which causes lactic acidosis. So that's about lactic acidosis. Now coming into the chronic complications, the first one is microvascular complications. Now it is related to the small vessels, and the complications are seen due to the damage of endothelial or mural cells of these small vessels. So it's seen in damage of endothelium or mural cells in the small vessels, and there are mainly three complications. First one is retinopathy, peripheral neuropathy and nephropathy. So first, retinopathy. Retinopathy is due to sorbitol accumulation in islands. Retinopathy simply means damage in the retinal area or in the eye. It's a complication seen in the eye. So it is due to sorbitol accumulation in the eyelids, and that causes cataract in younger ages, that is in early ages. Cataract is usually seen in old people, but in retinopathy, cataract is seen in younger individuals, and it is due to sorbitol accumulation. So this sorbitol accumulation is due to the increased polyol pathway. Because glucose is getting accumulated in our body, glucose gets converted into sorbitol with the enzyme aldose reductase. So glucose gets converted into sorbitol with the enzyme aldose reductase. So this is the basic equation for polyol pathway. So polyol pathway increases due to the accumulation of glucose, and sorbitol is produced, and sorbitol gets accumulated in the eye lenses, which causes cataract. So that is about retinopathy. Now peripheral neuropathy. In peripheral neuropathy, the individual faces paresthesias, foot ulcers and gangrenes in the extremities, in foot and in hands and all. So paresthesia, foot ulcers and gangrenes. So these are seen in peripheral neuropathy, and it is also due to the sorbitol accumulation in Schwann cells of the neurons. Sorbitol accumulation is due to increased polyol pathway, which we discussed just now. So the sorbitol accumulates in Schwann cells, which causes paresthesia. Paresthesia means tingling sensations in the fingers or in foot and all. So that is paresthesia. Paresthesia, foot ulcers, gangrenes. So these are seen in peripheral neuropathy, and it can also be due to production of advanced glycation end products, that is AGEs. So a short note about AGEs. So the chronic hyperglycemia, that is increased glucose concentration in our body for a longer period, it causes the production, it leads to the production of advanced glycation end products, that is AGEs. Some examples for advanced glycation end products are pentosidine and glucosipane. So chronic hyperglycemia causes or leads to the production of advanced glycation products, and examples are pentosidine and glucosipane. So these advanced glycation end products binds to the specific cell receptors, and that causes the cross-linking of cell proteins. So this AGEs binds to their specific cell receptors on the cell, and this binding causes it causes several production of several second messengers, third messengers, and thus the final result of binding to receptor is cross-linking of cell proteins, that is the proteins found in the cell. So cross-linking of proteins occurs, and that results in atherosclerosis, endothelial dysfunction, and glomerular dysfunctions. So advanced glycation end products binds to their specific cell receptors, that causes cross-linking of cell proteins, and this results in atherosclerosis, endothelial dysfunction, and glomerular dysfunction. So this is about advanced glycation end products. Now coming to nephropathy. In nephropathy, it's also known as Kimmel-Steele-Wilson syndrome, and that is renal failure due to proteinuria. Proteinuria means the excretion of proteins in urine, which is an abnormal condition. So that is known as Kimmel-Steele-Wilson syndrome, and renal failure occurs in that syndrome. In nephropathy, nephrosclerosis is also seen, which is due to glycation of basement membrane proteins. Because as the glucose concentration is very high, the basement membrane proteins gets glycated, that is the glucose gets added to these proteins, and that causes nephrosclerosis. So these are the reasons for nephropathy. So these three are the microvascular complications. A quick recap through these microvascular complications. First one is retinopathy. It is due to sorbitol accumulation in islands. It is due to the increased polyol pathway, and cataract occurs in young individuals. That is the manifestation of retinopathy. Now peripheral neuropathy, it is either due to sorbitol accumulation in Schwann cells or production of advanced glycation end products, and these causes paresthesia, foot ulcers, and gangrene. Now third one is nephropathy. It's called Kimmel-Steele-Wilson syndrome, and renal failure is seen, and glycation of basement membrane proteins of the nephrons causes the nephrosclerosis. Now coming into the macrovascular complications, it is seen in large and medium sized vessels. Plaque formation and thrombosis occurs in large and medium sized vessels, and also hypertension is seen in the individual due to the thrombosis and obstruction of the blood flow. Now if the thrombosis occurs in cardiovascular system, it leads to coronary artery disease and myocardial infarction. CAD and MI are seen if thrombosis occurs in the cardiovascular system, and if the thrombosis occurs in cerebrovascular system, that is in the brain, then paralysis, strokes, etc. are seen. And diabetic foot. Coming into diabetic foot, it is due to a combination of angiopathy and neuropathy. Angiopathy means damage to the blood vessels, neuropathy means damage to the neurons. So diabetic foot is a cause of both these, that is damage to the blood vessel as well as damage to the neurons. So that is about the diabetic foot. So macrovascular complications are cardiovascular, cerebrovascular, diabetic foot. And cardiovascular, it's coronary artery disease and myocardial infarction. Cerebrovascular, it's paralysis and stroke. Diabetic foot, it is due to a combination of angiopathy as well as neuropathy. Now in pregnancy, if the pregnant woman is diabetic, then the babies that are born will be bigger in size, that is their weight and size will be more. So in pregnant women, if they are diabetic, then big babies, that is babies with increased weight is born. And also there are high chances for abortion, premature death, as well as intrauterine death of the baby. So diabetes in pregnancy is very severe, and there are high chances for abortion, premature birth, and as well as intrauterine death of the baby. So this is all about the complications of diabetes. Now quickly, if we sum up, we saw signs and symptoms, that is glucosuria, which causes polyuria, which causes polydipsia, polyphagia, and in spite of polyphagia we can see weight loss and chronic recurrent infection. Complication, there are acute, chronic. Acute is diabetic ketoacidosis, hyperosmolar non-ketotic coma, lactic acidosis. Chronic, microvascular, macrovascular. Diabetic ketoacidosis, it's seen in type 1 diabetes mellitus. Ketosis is seen, it's because the acetyl CoA, more amount of acetyl CoA entering into ketogenesis. So ketone bodies are produced excessively. The investigations are these things: Benedict's Rothera's, pH less than 7.3, sodium concentration decrease, potassium concentration increase. Now the consequences of diabetic ketoacidosis, that is DKA, it's increased anion gap, reduced buffers, Kussmaul respiration, etc. etc. So the mnemonic is ARK PCODS. ARK PCODS. Now management: insulin IV, normal saline, bicarbonate IV, and hyperosmolar non-ketotic coma. It's the second acute complication. It's due to the dehydration of cerebral cells due to the hypertonicity around these cerebral cells. Now lactic acidosis, it's rare. It is due to oral anti-diabetic drugs. It is a side effect of oral anti-diabetic drugs. And these are the two metabolic reasons. One is due to anaerobic respiration, which causes lactate overproduction, and another is due to decreased TCA cycle, which causes lactate underutilization. Now the chronic complications, the first one is microvascular complication related to small vessels. Three complications are seen: retinopathy, peripheral neuropathy, nephropathy. Retinopathy is due to sorbitol accumulation in islands. Peripheral neuropathy is due to sorbitol accumulation in Schwann cells or production of advanced glycation end products. Advanced glycation end products are due to chronic hyperglycemia, and these binds to specific cell receptors, causes cross-linking of cell proteins, results in atherosclerosis, endothelial dysfunction, glomerular dysfunction. Now nephropathy, it's called Kimmel-Steele-Wilson syndrome. Renal failure is seen, and glycation of basal membrane protein causes nephrosclerosis. Now macrovascular complications, it's seen in large and medium-sized vessels. Due to thrombosis, which is due to plaque formation. So plaque formation leads to thrombosis. Hypertension is seen in these individuals, and these are cardiovascular, which causes coronary artery disease, also MI, myocardial infarction. Cerebrovascular, that is if thrombosis occurs in cerebrovascular system, then it causes paralysis, stroke. And diabetic foot, it is due to a combination of angiopathy as well as neuropathy. Now in pregnancy, if the pregnant woman is diabetic, then big babies are born, and there are high chances for abortion, premature birth, IUDs. I hope this was clear. Thank you.